Hi guys, this is Mikhail from Prague ICU, and today we will show you the heart anatomy. Here you can appreciate the gross specimen of the human heart. The heart consists of four main chambers: the left and right atria and the left and right ventricles. The chambers are separated by septa and valves. The base of the heart faces superiorly, posteriorly, and medially. It is the place where great vessels enter and leave the heart. The apex of the heart faces inferiorly, anteriorly, and laterally. The long axis of the heart goes from the opening of the superior vena cava diagonally, ventrally, and caudally to the apex of the heart. Several surfaces can be described on the heart. The anterior surface is formed mainly by the right ventricle and partially by the left ventricle. The inferior surface faces the diaphragm and is formed by the posterior surfaces of both ventricles. The right and left pulmonary surfaces are formed by the right atrium, the left atrium, and left ventricle, respectively. The sharp margin of the right ventricle that you can see here is the right border of the heart, the so-called margo acutus. The more rounded margin on the left ventricle is the left border, margo sinister. This groove right here, separating the atria from the ventricles, is the coronary sulcus. It contains the right coronary artery, the circumflex branch of the left coronary artery, the great cardiac vein, and the coronary sinus. The groove on the anterior surface of the heart is the anterior interventricular sulcus. It is formed by the interventricular septum and contains the left anterior descending artery and the great cardiac vein. The posterior interventricular sulcus is this groove over there on the posterior surface of the heart between the right and left ventricles and contains the posterior interventricular branch and middle cardiac vein. Finally, there is the sulcus terminalis cordis, formed by the crista terminalis and creating the border between the proper right atrium and sinus venosus. Now, let's proceed to the description of the individual heart chambers. We will start with the atria. Both the left and right atria can be divided into a proper atrium and an auricle. From the embryogenic point of view, the auricle is the only true atrium, and the proper part is in fact a piece of the embryonic vein, incorporated into the heart during its prenatal development. That's why the internal surface of the proper atrium is smooth, but the auricles are wrecked by the muscle fascicles called pectinate muscles. The right auricle is broader than the left auricle. It has a roughly triangular shape with a broad base, and in contrast to the left auricle, the pectinate muscles reach beyond the border of the auricle and extend to the proper right atrium. This tiny anatomical detail is, in fact, the single most reliable defining structure of the morphologically right atrium. In the top portion of the atrium, we can see the opening of the superior vena cava. And here you can appreciate the opening of the inferior vena cava. Normally, it is partially demarcated by the Eustachian valve, directing blood through the foramen ovale to the left atrium during prenatal life, but it is not properly seen in this specimen. Here you can see the coronary sinus, the opening of the main vein draining blood from the heart. Normally, it is partially demarcated by the Tebesin valve. Inside the right atrium, you can also appreciate the muscular ridge called the crista terminalis, separating the sinus of the vena cava from the rest of the proper right atrium and corresponding to the sulcus terminalis cordis that we saw from the external surface. Sometimes we can also see a small elevated muscular ridge between the superior and inferior vena cava called the intervenous tubercle. In the right atrium, we can also define an anatomical region called the triangle of Koch. Its borders are the septal cusp of the tricuspid valve, the opening of the coronary sinus, and the tendon of Todaro, a tiny cartilage that is the part of the cardiac skeleton. The triangle of Koch is an important anatomical region since it contains a part of the conduction system, the atrioventricular node, at its tip. The atria are separated by the interatrial septum. It is a thin, partially fibrous, partially muscular barrier separating the left and right atria. From the right side, you can appreciate the oval fossa, an oval-shaped depression that is a remnant of the embryonic septum primum and septum secundum that subsequently merged during the embryogenic development of the heart and closed the fetal shunt called foramen ovale. The border of the oval fossa, limbus fossae ovalis, is this elevated ridge around the margin of the oval fossa. Following the bloodstream, we leave the right atrium and enter the inflow tract of the right ventricle. An opening between the atrium and the ventricle is called the right atrioventricular orifice and is bordered by the right atrioventricular valve, or tricuspid valve. The valve consists of the anterior, posterior, and septal cusps. The individual cusps are connected at the anterolateral, posteroseptal, and anterior-posterior commissures. The anterior cusp is anchored by tendinous cords to the anterior and septal papillary muscles, the posterior cusp to the posterior and septal muscles, and the septocusp to the posterior and septal papillary muscles. The cords also, in contrast to the mitral valve, attach to the free wall of the ventricle. As you can see, the internal surface of the inflow tract of the right ventricle is not smooth, but is racked by thick muscular bundles called trabeculae carneae. The outflow tract of the right ventricle is separated from the inflow tract by this crest over there, called the supraventricular crest. Here you can appreciate a thick muscular bundle connecting the interventricular septum with the anterior papillary muscle, called the septomarginal trabecula or moderator band. It is a thick muscular trabecule containing the right bundle branch of the heart conduction system. Following the bloodstream, we leave the outflow tract of the right ventricle and enter the pulmonary trunk. The opening of the pulmonary trunk contains the pulmonary valve. The valve is composed of three semilunar cusps, the anterior, right, and left. The pulmonary trunk gives rise to the left and right pulmonary artery, bringing the deoxygenated blood into the lungs. The right and left ventricles are bordered by the interventricular septum. It consists of the muscular part and the membranous part, the second being a component of the cardiac skeleton. If we continued slightly more cranially, we would reach the atrioventricular septum, a fibrous barrier between the right atrium and the outflow tract of the left ventricle. Now, let's get a closer look at the left part of the heart. As you can see, the auricle of the left atrium is thinner compared to the right auricle, and the pectinate muscles are confined to the auricle and do not reach the proper atrium. 4 pulmonary veins open to the left atrium, which you can see here. The upper and lower left pulmonary veins bring newly oxygenated blood from the left lung, the upper and lower right pulmonary veins from the right lung. The opening between the left atrium and left ventricle, the left atrioventricular orifice, is bordered by the left atrioventricular or so-called mitral valve. The old term of the mitral valve was the bicuspid valve, since it consists of 2 cusps, the anterior and the posterior. The cusps attach to the papillary muscles via tendinous cords. In the left ventricle, we can appreciate anterolateral papillary muscle and posterior medial papillary muscle. Both cusps attach to both papillary muscles, but in contrast to the tricuspid valve, there is no attachment to the free wall of the ventricle. The cusps are connected to each other at the anterolateral and posteromedial commissures. Through this opening, we can enter the inflow tract of the left ventricle, proceed to the outflow tract, and then enter the ascending part of the aorta. The smooth part of the left ventricle below the aortic valve is called the aortic vestibule, which continues to aortic orifice, containing the aortic valve. As you can see, there is a fibrous continuity between the anterior cusp of the mitral valve and the aortic valve, so-called aortomitral continuity, in contrast to the tricuspid and pulmonary valves. The aortic valve consists of the left, right, and non-coronary seminal cusps. Subtle dilations of the aortic wall behind the left and right cusps are called the left and right aortic sinuses of Valsalva. In these spots, the left and right coronary arteries arise. The posterior cusp doesn't contain any arterial opening, and it's thus called the non-coronary sinus of Valsalva. And now let's look at the coronary arteries. As we already mentioned, the right coronary artery arises from the right aortic sinus and the left artery from the left aortic sinus. The right coronary artery runs in the coronary sulcus between the right auricle and the right ventricle. The right marginal branch is this large branch for the right ventricle, passing over the right heart border. The first terminal branch of the right coronary artery is called the posterior interventricular branch, running in the posterior interventricular sulcus. The second terminal branch is the right posterolateral branch, supplying the right part of the posterior wall of the left ventricle. The left coronary artery has only a 1 to 2 cm short stem and then splits into the left anterior descending artery and circumflex branch. The first one descends in the anterior interventricular sulcus to the apex of the heart and supplies the left ventricle. Its first branch is called the conus branch, supplying the left ventricle outflow tract. The diagonal branch is the thickest branch that runs diagonally across the ventricle towards the apex of the heart and supplies the anterior wall of the left ventricle. Multiple anterior ventricular and interventricular septal branches supply the left ventricle. The circumflex branch, the second main branch of the left coronary artery, runs in the coronary sulcus between the left auricle and the left ventricle and supplies the left atrium and ventricle. It gives anterior ventricular branches for the left atrium and ventricle, atrial branches for the left atrium, and the left marginal branch that supplies the lateral wall of the left ventricle. The terminal branch is called the left posterolateral branch, supplying the left part of the posterior wall of the left ventricle. Last but not least, we should look at the heart veins. Venous blood is drained from the heart in three ways. The main venous drainage goes via the coronary sinus. It is located in the coronary sulcus on the inferior wall of the heart and opens into the right atrium. It is a confluence of three main veins: the great cardiac vein, beginning in the anterior interventricular sulcus and collecting blood from the area supplied by the left coronary artery; the middle cardiac vein, going through the posterior interventricular sulcus and draining blood from the area supplied by the posterior interventricular branch; and the small cardiac vein, draining the area of the right heart border. The second way of blood drainage goes via the anterior veins of the right ventricle, which drain blood from the right ventricle wall directly into the right atrium. The third way is represented by small cardiac veins called Tebessine veins that direct blood individually into all four chambers of the heart. During cardiovascular implantable electronic device insertion, the atrial pacing lead is inserted through the superior vena cava and is implanted to the right auricle. The right ventricular lead goes through the tricuspid valve and is implanted to the mid-interventricular septum. In case of resynchronization therapy, the left ventricular pacing lead is inserted through the coronary sinus to one of the cardiac veins on the surface of the heart, preferably to the posterolateral branch. Anatomically, here is the superior vena cava, the right auricle, tricuspid valve, oval fossa, and here is the entry to the coronary sinus. In conduction system pacing, to reach the left bundle branch area, the special type of electrode is implanted deeper to the mid-interventricular septum. The Micra pacing system is a single-chamber pacemaker system inserted through a femoral vein. The device is fixed to the septum myocardium with 4 electrically inactive nitinol tines. In patients with typical atrial flutter, the cavo-tricuspid isthmus ablation is considered an effective first-line treatment. Here is the inferior vena cava, and here is the tricuspid valve. In patients with atrial fibrillation, the pulmonary veins are electrically isolated using special ablation catheters. Moreover, here you can appreciate the Farapulse pulse field ablation catheter, during which the electric fields create microscopic pores in cell membranes in a process called electroporation. And this is all for now. Thanks for watching and stay tuned for more educational videos.